So in the last segment of the screencast, if we are going to use the broadest definition of failure to thrive as a failure to meet expected standards of growth, we're going to talk about its etiologies and then classify these etiologies of failure to thrive and malnutrition in particular to help develop a framework so that we can organize all the various causes, and this will then help us with our clinical assessment. So another question to open this portion of the discussion. And so pause the video to review the growth curve and try to answer this question. The answer here is insufficient intake leading to malnutrition. So you do see both here and in familial short stature and constitutional delay of growth and advancement a downward trend in weight percentiles. However, in this case, there is a disproportionate decrease in weight and therefore decrease in weight for length, and that is a key distinguishing feature that is concerning for malnutrition, and again distinguishes it from necessarily some of the older, more traditional definitions of failure to thrive. So this is a summary slide of all the causes of failure to thrive or faltering growth. So once you've excluded the masqueraders that we previously alluded to, then you are left with this dichotomy here, where there is either concern for malnutrition or decreased intrinsic growth potential, which is more significant than that seen with just familial short stature. So when we talk about malnutrition, it reflects an imbalance between intake and needs, and therefore you can subdivide it as not enough in, or inadequate intake, not enough being absorbed or retained, increased needs or energy expenditure, or altered metabolism or utilization of nutrients. On the other hand, growth may be limited by an underlying condition, and therefore linear growth impairment may also be a key feature with the conditions noted in the bottom. So for example, some syndromes are associated with short stature and correspondingly low weights. And as another example, with respect to neurological impairment, children with spastic hemiplegia have been known to have smaller breadth and length on the affected side, suggesting that the neurological deficit will influence growth. And as another example, where weight may be affected, some patients with neurological impairment have progressive muscular atrophy due to the underlying disease, even though they are not necessarily malnourished. So I mentioned earlier that some may consider failure to thrive to be a pejorative term, and this was also because of the associated traditional view of failure to thrive or growth failure as a dichotomy, for more specifically due to either an underlying medical condition, which was often referred to as organic failure to thrive, or due to psychosocial causes, otherwise known as non-organic at the time, which usually constituted for approximately 90% based on the literature that was read. The implication of a non-organic label was that the child was intrinsically normal and that failure to thrive was due to environmental factors, most commonly attributed to parental failures like neglect or indifference. Obviously, that isn't the case, and new classification schemes, as exemplified here by that proposed by the Aspen Group, or the American Society of Parental and Enteral Nutrition. Well, these new schemes classify etiologies as illness-related and non-illness-related, but also recognize that there may be either or both at play, with possibility for interaction between the two. It also divides the etiologies that are illness-related into either acute or chronic, as you can see there. And it also specifies or requests the specification of whether or not there is inflammation involved or not. This is important because there's been increasing focus on the effects of inflammation on malnutrition and growth impairment, in large part thought to be cytokine-driven, with effects on anorexia or lack of appetite, increasing resting energy expenditure, and also inducing a catabolic state with skeletal muscle breakdown. So this is important because, again, if there's lots of inflammation, even additional nutritional supplementation may only rarely reverse or prevent muscle loss in these instances. So to illustrate the potential complexity of failure to thrive or malnutrition, I took the example of cystic fibrosis. So while this is traditionally listed as a, quote, organic etiology for failure to thrive due to malabsorption from pancreatic insufficiency, the reasons for poor growth and malnutrition can actually be wide-ranging. So using that prior schematic, There are non-illness related factors that can be at play related to the lifestyle, food security, anxiety around eating, maybe symptom related, and even concerns about body image, several of which may be influenced by disease. On the other hand, there are a lot of illness related factors beyond just that of malabsorption, and these can be divided into acute and chronic, and several of these can involve inflammation, and the impact or severity of some of these can be due to environmental or non-illness related factors, for example, adherence to physiotherapy and pancreatic enzyme therapy. So then if you look at the right side and see the different categories of malnutrition that we previously alluded to in green, and then started drawing lines from each of these illness and non-illness related factors to these broader categories, you could argue that some things like chronic lung disease, for example, can affect both intake and energy expenditure, while others like gastrointestinal infection can simultaneously affect intake and malabsorption. And so these lines could make this become quite a convoluted picture. But again, just an example to show that many factors can be at play, and using a simple dichotomy of organic versus non-organic may not be appropriate. So with these caveats in mind, I'm going to now present a clinical approach to the assessment of failure to thrive. With respect to the history, though, I break it down in this fashion, and I'm going to go through each of these points in further detail, but this is just an orientation slide to show you how I would approach this. Now, given that the presenting issue here is poor growth, I consider the HPI as an attempt to try to discern the nature and the timeline of the growth concerns while reviewing the growth curves if present, and then trying to look for events or issues that may correlate with the onset or progression of the growth difficulties. Then the next 2 points, the dietary history and the review of systems or symptoms, I use to assess for potential factors that may relate to malnutrition. And then the next 2 points, the antenatal past medical history and the family history, are really looking for any clues that might affect either the intrinsic growth potential or other conditions that may affect malnutrition. So it's kind of looking for both simultaneously. And then finally, looking at the developmental and psychosocial history is important because it can help us determine the sequelae of malnutrition if present, and then also to determine if there are developmental impairments that may be associated with a cause that would explain the failure to thrive, and then also to see how this has impacted the family, or alternatively how the psychosocial environment may be impacting the feeding environment. So growth history begins with a review of the growth chart, obviously if available. So recognizing the relative decline in weight, height, and or head circumference percentiles can help distinguish whether the growth pattern is concerning for undernutrition or something else. This is what I was alluding to with the earlier question. So when there is malnutrition of any cause, the weight will be affected first, and then if the malnutrition persists, then stunted linear growth may be noted, and finally the head circumference is affected. So therefore it's reflected in a couple of ways. The first thing is that when you look at the pattern, the weight Z score is what decreases first, and so you can see that on the bottom. And then because the weight Z score decreases more prominently, the weight relative to the length, or the BMI, is often low, which is not featured in this curve, but would be a prominent feature, and as we mentioned, is also considered in our definitions for malnutrition. So that's why this would lead you to believe malnutrition of various etiologies, and again distinguishes it from some of those failure to thrive masqueraders like familial short stature. The second scenario you might see is where the weight and the height or length are somewhat similarly decreased, and also the decline is noted at a similar time, with the head circumference relatively unaffected. So this is usually associated with a normal or sometimes increased weight for length, or BMI, and that would distinguish it from malnutrition as the cause of this abnormal growth pattern. So this, again, as we talked about, may be how a curve in familial short stature or constitutional delay might look, but the other possibilities would include endocrinopathies. Also, if you have chronic malnutrition and you don't have some of the earlier data where the initial decline in weight may not be documented first, this also may be a pattern that you would see as well. The third scenario is where the weight, the height, and the head circumference are similarly and significantly affected. So we wouldn't use a curve like this that I'm showing here typically, but it does illustrate that the height age, weight age, and head circumference age are all lagging behind that of a normal developmental age, and each appear to be decreased to a similar extent and with similar timing. So when you see this pattern would raise concern for conditions affecting the intrinsic growth potential, like a chromosomal or genetic abnormality, also seen with symmetric intrauterine growth retardation and other perinatal insults, also may be seen sometimes in inborn errors of metabolism. And I put here in chronic malnutrition, again, in the very severe late phase. But again, the pattern is that the height, the weight, and the head circumference are all decreased with similar pattern and similar timing. So if we now move on to the dietary history, this is the critical area of exploration to determine if there is an adequate intake, given this is the most common contributing factor to failure to thrive. And these are just a list of some of the important reasons for having an adequate intake that should be explored. So not enough being offered due to a lack of money or food security, challenges with breastfeeding or milk production, inadequate knowledge of children's feeds or needs with respect to the diet, and rarely neglect or abuse. Oral aversion can be due to various factors, and I use a little bit of a mnemonic here to help me remember the A, B, C, D, E, F, G, H's, and I's. So you can see these are things that will come out through the history, but are just things to consider. So allergy, altered bowel habits, chewing or swallowing dysfunction, dental issues or oral pain that's leading to difficulties, esophagitis due to either reflux or eosinophilic esophagitis or other causes, frequent infections or illnesses, gastroesophageal reflux disease or altered gastric emptying, hand-mouth coordination difficulties, either with really young patients or those with neurological impairments, or difficulties with the interaction around mealtime with caregiver or those providing meals, difficulties with temperament, or iatrogenic causes that may lead to oral aversion. Inadequate eating and oral skills, again, can be developmental or maturational issues. There may be dysphagia from either oropharyngeal or esophageal causes. Gastroesophageal reflux disease, when severe, can lead to oral aversion, or less commonly, because of excessive regurgitation with spit-ups, can lead to inadequate retention of food, which also would then lead to the last point, which would be vomiting due to various etiologies. So to determine if there's an intake problem and what the contributors may be, you start with a dietary history. If they're breastfed, does the mom experience a letdown reflex at the beginning of the feed? Are the breasts engorged, suggesting difficulties with feeding? Is there an adequate latch, sucking, or swallowing? How long are the feedings lasting for? Does the baby feed on one breast or both? Screen for concerns regarding cracked or painful nipples or mastitis to see if there's any concerns. That's a big part of the history. Formula fed, you obviously have the benefit of knowing what the volumes are, but the key thing is to ensure that they're adequate and whether the formula is being mixed appropriately, which may not be the case. There can be difficulties with behavior or interaction around meal times, and so you're going to ask about that. And then a very important way to estimate the caloric intake would be to actually have them prospectively do a 3-day record of what is taken in for those after the introduction of solids. But if not available, you can also do a 24-hour recall. So after this, there are a few things on review that will suggest difficulties with intake, such as tongue thrusting or drooling or pocketing food or chewing food, which might suggest difficulty with the oral phase. The second row there would be symptoms to ask about when you're screening for aspiration or respiratory difficulties or reflux or vomiting. The third line there would be looking for evidence of tiring with feeds that may indicate an underlying cardiorespiratory condition, given that feeding is probably the most exercise that a baby will have. And then the fourth line, asking about wet diapers and stools, is obviously very important as an indicator, a surrogate of the adequacy of volume intake. So after exploring intake, the next step is to assess whether there's concern for malabsorption. And there are a large number of different causes of malabsorption in pediatrics, but broadly speaking, I think about the pathway of fat digestion and absorption because it's the most energy dense macronutrient, and the steps in digestion and absorption can help you recall the three main groups of conditions that would lead to malabsorption. So they are pancreatic insufficiency, which cystic fibrosis is very much the most common cause. There's cholestatic liver disease, which is often usually associated with other features. And then intestinal disease being the most common category, with some of the more important conditions in pediatrics to consider that are listed there. So keeping that in mind, the best way to assess for malabsorption on history is to continue on your history, as you normally would with review of systems, with targeted questioning. The obvious initial question is about the presence of diarrhea, and more specifically if there's evidence of steatorrhea, which would maybe be described as bulky or greasy or oily stools, stools that may stick to the toilet bowl or float, or watery loose stools, which may be seen in the context of fatty acid or bile acid or carbohydrate malabsorption. And in the case of carbohydrate malabsorption, stools are often acidic and irritating to the perianal skin, so you might get a history of rashes. Acolic stools obviously would be chalky and white and sign of cholestasis. Abdominal pain, distension, and flatulence could be symptoms of malabsorption or associated with that. And then edema or swelling could be features of hypoalbuminemia if there is protein loss from the intestine, as associated with an enteritis or enteropathy. And then you could also ask for symptoms that may be associated with various nutritional deficiencies, such as bleeding tendencies associated with vitamin K deficiency, or pathological fractures associated with vitamin D deficiency. So moving along, many acute and chronic illnesses can increase energy expenditure, and some examples could include congestive heart failure, congenital heart diseases, cystic fibrosis, severe asthma, chronic kidney disease, tubular acidosis, hyperthyroidism, diabetes, adrenal insufficiency, inborn errors of metabolism, primary acquired immunodeficiencies, systemic disease, or cancer. So this is where you would do a good review of systems that may clue you into some of these conditions based on some symptoms that may be reported, including fatigue, wheezing, snoring, diaphoresis, tachypnea, coughing, recurrent infections, gastrointestinal symptoms. Particularly with neuromuscular conditions, you may get a history in infancy of floppy, baby, weak cry, and again, sleepiness and lethargy or irritability. So moving on to birth history, you're going to do a very good history here looking for maternal risks for poor growth in utero, antenatal ultrasounds, anomalies, history of oligo or polyhydramnios or IUGR, uterine growth retardation, and then you're going to get a good labor and delivery history and a neonatal history that may point to, again, etiologies that may explain poor growth around birth and delivery, and then ask about newborn metabolic screen. Family history, very important, as we already mentioned, to get the heights, in particular, of the first degree relatives, particularly the parents, as well as some of the weights, and then the pubertal onset of the parents as well. And then you're also going to screen, of course, for any pertinent conditions on family history that may explain the altered growth pattern, either due to malnutrition related conditions or due to altered intrinsic growth potential. And then, as we mentioned, the developmental review, and then very important to go through the psychosocial history to get a sense of impact on the family and the child's environment. So moving on to physical examination, you're going to start with anthropometrics. If you haven't already gotten the weight measurement, the length, and the height, please get that. Head circumference if they're younger, and consider a mid-upper arm circumference as we talked about, as it's quick and easy to do. Looking on general inspection, these are some things that you may look for as noted there, such as dysmorphic features, pallor, and then to look at the neurodevelopmental status of the child based on observations to see if it's consistent with what was reported. And then you're going to also look for nutritional status, as we mentioned, looking for signs of muscle or fat wasting or other changes that may suggest nutritional deficiencies. Depending on the age, obviously if they're peripubertal, Tanner staging would be important. And then parent-child interaction and observation of feeding, if possible, can be very helpful. And then end with a system-focused exam, going head to toe or in whatever order you go. So, for example, from a neurologic perspective, assessing the cranial nerves as best as possible, particularly those involved in swallowing, if that is a concern. Also looking at deep tendon reflexes and primitive reflexes, and in infants, peripheral and central tone, as well as muscle bulk. On the head and neck inspection, if there's concern for recurrent emesis, do look for signs of increased intracranial pressure, which in an infant with a persistent open fontanelle would allow you to assess by palpating for bulging fontanelle or looking for widened sutures, and in older patients, obviously doing a retinal examination. Looking at the craniofacial appearance to look for clues that might suggest a concern with the oral phase of swallowing, particularly, as an example, cleft palate and other features. Cardiorespiratory abdominal exam, and as we mentioned before, looking for hepatosplenomegaly, particularly in cases of severe acute malnutrition associated with edema, and then again, other parts of the exam as directed. So moving on to investigations, remember, first, it is not required for all scenarios. For example, familial short stature does not require further investigations. It, in fact, requires reassurance and education. Observational follow-up may be all that is required, and allied health professional assessment can be very valuable in both the initial assessment and follow-up. And when I say observational follow-up, it would mean following the growth pattern and providing initial support as necessary if there's a concern for malnutrition, and then providing further assessments as needed, for example, OT and SLP if the oral motor function is of note or concern. So now we're going to move on to some basic workup, quote unquote. Before I do that, I just wanted to highlight that there was a really good study in 1978 of children who were hospitalized for what was concerning for failure to thrive at the time. Only 18% at the time had proven organic causes, and all of these patients had a specific diagnosis strongly suggested by history and physical examination. In all 185 patients who were hospitalized, 36 out of the 2,607 lab tests that were run were of diagnostic assistance, and all of the positive results were in the group with a proven organic cause. Again, suggesting the importance of targeted testing. So these tests do not need to be ordered for every patient with failure to thrive. However, if the initial assessment based on the history and physical does not lead you to a specific diagnosis or concern for a specific etiology, these would be reasonable to test for. As you can see, some abnormalities here are not going to be specific for an underlying condition necessarily, but they may point you towards certain etiologies. So for example, if there's iron deficiency anemia, increased inflammatory markers, kidney or liver test abnormalities, abnormalities in the glucose or albumin, hypoimmunoglobulinemia, or altered thyroid status may also point you there. Just also a quick note that the celiac screen should only be done in patients who are receiving gluten in their diet after the introduction of solids. From that same article, here are some other investigations that may be considered, again based on the history and physical. For example, the top 4 listed there, 4 rows, would be really important if you're concerned about fat malabsorption or malabsorption in general, as they screen for conditions associated with fat malabsorption such as pancreatic insufficiency and cystic fibrosis, or just look for causes of malabsorption in general. Bone age would be helpful if you're considering failure to thrive secondary to those masqueraders such as familial short stature or constitutional delay, and then other imaging and specialist referrals as needed. And then when it comes to management, it really is dependent on, first, whether or not you believe failure to thrive is truly representing malnutrition, and whether or not the history and physical leads you to a specific etiology. So obviously, the etiology that you identify will help target your therapy. But obviously, nutritional repletion is the mainstay, and it may, again, the best way to tackle it may be dependent on the etiology that you identify. Both the non-illness and the illness-related factors need to be considered, even in cases where an illness is identified. And again, this is particularly where the allied health can be of great benefit and support for you. So in summary, failure to thrive is defined as inadequate growth according to expected standards, and is considered a sign of undernutrition which has to be confirmed with further assessment. It is possible for infants and young children to cross percentile lines or be considered underweight, as part of what would be deemed actually their normal growth course without a pathologic abnormality identified. As we talked about, growth can be affected by the genetic potential, factors affecting nutrition, primarily the intake and the energy requirements. Inflammation is very important, as well as psychosocial and environmental factors. And finally, the pattern of failure to thrive based on the growth curve, and an etiology-oriented history is very helpful in approaching both the differential diagnosis and the investigations. So I'm just going to leave you with these last two questions here to review, so take a moment and pause to look at this. So the answer here would be that a formula-fed infant would be more likely to be classified as underweight within the first 3 to 6 months because they generally gain weight at a slower rate than breastfed babies, but then become heavier after 6 months. And then lastly, take a moment to pause, but in newer classification schemes for the etiologies of malnutrition, there is increased emphasis on the effects of inflammation on malnutrition. In fact, as we already mentioned, we are less focused now on dichotomizing failure to thrive as specifically due to illness or non-illness related factors, recognizing there is an overlap between them. So that is all. I'd like to acknowledge Dr. Machida, who helped provide me with some pictures and some of the original content that led to my expansion on this topic. These are just the final slides here. Thank you.